Nigel, having reviewed the history of the NHS, what conclusions did you come to about the sort of performance management system that can help us to continually improve but doesn't become too intrusive in the way that trusts operate?
The NHS has been enormously centralised, particularly in the early part of the last decade, and it's a bit of an outlier really when you compare it with most of the rest of Europe in the extent to which government wants to control right down to the minute detail, including in one extraordinary case, getting the Secretary of State's office ringing the chief executive of a trust had suspended a neurosurgeon for taking too many croutons because it was embarrassing. So this reign of what Carol Proper describes as targets and terror can have quite a disabling effect on boards if they're not very, very careful. And the ones that we spoke to had really focused on making sure that they knew what the right thing to do was and were able to push through some of that, but others found it a struggle.
Okay, so a shift away from targets would be a good thing?
Well, targets have their place, and I think one of the things that many people commented on was that the current set of objectives, call them that rather than targets, that people are starting to develop are more aligned with what organisations feel is the right thing. The real problem, I think, with particularly the early part of the last decade was people just did not feel that the targets they were being asked to pursue really mapped on to what they wanted to do as an organisation. So I think it's helpful to have a direction. It's important for commissioners and for government to say this is what we think is the objective of the system, but it's not the right thing to tell them how to do it, which is what we've had a lot of in the past.
Your review has shown that NHS boards in 2011 spend more time talking about quality and patient experience than they did a decade ago. Last week we heard that the CQC had undertaken spot checks in 100 hospitals and found quite a lot needing to change. How do you explain that?
Well, I suppose one of the problems is that hospitals are huge and complex organisations, and it takes a long time from having a culture shift to that really going right the way down the organisation into what happens on individual wards. And there's still a problem in quite a lot of organisations that there's a bit of what Henry Mintzberg, the management theorist, describes as a concrete floor between clinical work and boards. And there'll be some places where they're having that conversation and it isn't getting through the floor. There are others where they are, but it's taking time to penetrate. And in some places there are some issues about intractable problems with the culture of nursing and other caregivers and how they behave.
What do you think boards need to do then to create a culture of improvement in quality and patient experience?
Well, a lot of this is about how the boards themselves provide leadership. They need to do more to get information so that some of that material, for example, that the CQC discovered doesn't come as a surprise. And I would say that what they really need to be doing is empowering their frontline leaders, clinical directors, ward sisters, and holding them to account for demonstrating we've got measurable change, and so measurement is really important. The other thing that's come through from the work, I think, is the importance of curiosity about what other people are doing too, so that you don't get left behind. You think you're doing fine, but actually the world's moving on faster than you are.
Nigel, you highlighted in your paper that the NHS has been poor at differentiating between chief executives who are poor and those who are unlucky. What would you like to see change?
Well, I'd like to see a situation in which regional health authorities, strategic health authorities, or whatever incarnation of intermediate organisations don't try and play chess with individual leaders, and that organisations themselves ought to be taking responsibility for their leaders, and it should not just be a decision taken quite a long way away by people who don't always know the context.
One of the themes we've been discussing this morning is whether foundation trusts should hold their board meetings in public. Do you think that would make a difference to public confidence?
I'm not sure it would. It's more about what the board is saying about transparency and about their willingness to talk about important things, which is a big signal to staff as much as it is to the public. I think it's also about showing that they're being accountable for what is very large sums of public money. I think there are some arguments about why private meetings can be appropriate, but I think we heard today that actually the way to deal with that is to say, look, there are some things where it's entirely legitimate that we should talk about this in private. They're either about our commercial strategy, which we might not want to share, and we wouldn't expect private hospitals, private providers to be sharing that either. But and there might maybe some confidential things, but on the whole, we have a culture of openness here, which means that the accusation that somehow things are being hidden is much harder to make, and also people are conducting their business in that sort of glare of public scrutiny, which I think is likely to improve how they do it.
Nigel, thank you very much. It's a fascinating paper, and it's reassuring to note that there's some positive improvements around the focus on quality and safety. Thank you.
Thank you.